Today we're talking about diseases of the central nervous system. And we're rounding out with this lecture, I suppose, a collection of diseases. Diseases of the peripheral nervous system, and then also diseases of skeletal muscle, which are in a different module altogether. But these are sometimes an interrelated category of diseases because of overlapping symptoms. We are going to learn about an awful lot in this lecture. This is kind of tough for you all because this is basically all of neurology in 2 hours. And so we're going to have diseases like stroke, we're going to have diseases like Alzheimer's disease, Parkinson, multiple sclerosis, epidural, subdural hematomas. There's a lot. We're going to move very quickly. But this is all material that is important to know because our patients may list these on their medical history. They may be taking medications for these conditions. They've had a surgery or survived one of these conditions. So today is central nervous system. We learned about peripheral nervous system already, and we all know the difference between the two. As we talked about a variety of diseases, and as we talk about diseases that specifically affect neurons, I want us to remember that neurons are incapable of cell division. This is unlike, for example, epithelial cells, which replicate so frequently that the entire skin or mouth lining turns over every 3 weeks. Neuronal injury can be entirely acute. This would be in the setting of oxygen depletion or trauma. What might be an example of a disease that causes clinical manifestations because of acute oxygen depletion? Hypoxia. So there would be some kind of a state of hypoxia. But what is a common disease? Or can we think of a common condition that is significant because it results in acute hypoxia? So thinking of diseases that we'll actually talk about in this lecture, but diseases which we all know about.
Ischemia, atherosclerosis.
So what about, and you can certainly have atherosclerosis connected to the central nervous system. So something that we won't learn about because we only have 2 hours is there can be generalized ischemia to the cerebrum because of really, really dense deposits of atherosclerosis within the internal carotid artery. This is to the point sometimes where vascular surgeons need to go in and they need to do a procedure known as an endarterectomy. Basically, you go in and you clean out, you debride all of the cholesterol deposits among the internal carotids that are plugging up the internal carotid so that you can get adequate blood flow into the brain. But what is a much more clinically and public health significant example of acute oxygen deprivation? It would be stroke. What is stroke? Now, I know we're going to talk about stroke, but we already know a few things about stroke. What is stroke? Yeah, so for example, you get a blood clot in the brain. It's like if you get a blood clot to a coronary artery, you get a myocardial infarction. If you get a blood clot to some artery in the brain, you get a stroke. Chronic neuronal injury. What are some disease processes that are characterized, or what are some diseases that are characterized by chronic neuronal injury? Yeah, we can guess as to what are some common chronic diseases like Alzheimer's and Parkinson. Those are examples of chronic neurodegenerative diseases that result in chronic neuronal injury, or I should say they're caused by chronic neuronal injury. The central nervous system, the skull and the spinal canal are a lot like the tooth. The tooth has a fixed volume. The pulp chamber has a fixed volume because of the hard tissue around it. The same is true for the central nervous system. We're going to quickly talk about hydrocephalus and herniation. I'll only mention in passing here cerebral edema, which is swelling of the brain. These are 3 consequences of elevated pressure in the cranial cavity. Elevated pressure in the skin, for example, doesn't really result in a lot of problems. You just have a big little bruise or a big little swelling, but you don't have the opportunity to swell in the central nervous system because the tissues are encased by rigid hard tissue. Cerebral edema is simply cerebral edema in the setting of a variety of other diseases. But let's talk about hydrocephalus and then we'll talk about herniation. Hydrocephalus is a disease of cerebrospinal fluid. Hydrocephalus is a disease disease of excessive cerebrospinal fluid, which remember normally circulates throughout the ventricular system and then goes down into the spinal canal. Cerebrospinal fluid is produced by the choroid plexus. Hydrocephalus results when there's an abnormal accumulation of cerebrospinal fluid within the ventricular system. This is almost always due to some kind of obstruction that prevents egress of cerebrospinal fluid out of the ventricular system. This is usually because of a developmental anomaly, just an area, a narrowing of some sort of foramen or one of the canals through which the fluid travels. Occasionally it can be to disease or to trauma if there's some tumor that is blocking the flow of cerebrospinal fluid. That can result in hydrocephalus. But hydrocephalus is a disease of accumulation of cerebrospinal fluid because of a blockage or obstruction in outflow. Just an internet image to really illustrate what is going on pathophysiologically in most cases. Of course, most cases aren't at all this significant clinically. But hydrocephalus is characterized potentially in infancy while the calvarial bones are still forming and while they're still soft by an enlargement of the head because of the increased pressure and the increased volume that is being taken up by the blocked cerebrospinal fluid within the ventricular system. In adults, hydrocephalus is not going to present as an increase in head size because the calvarial bones are already fully fused. So there will be clinical signs and symptoms that are related to increased pressure. Some of the clinical signs and symptoms that are related to increased pressure include the things I've listed here: headache, impaired vision if there's compression of an optic nerve, cognitive difficulties, and a few other things that I've written here for you all to read. Hydrocephalus is treated simply enough. It's one of those treatment algorithms that you could invent if you were in charge of inventing, just like dental caries. Let's take a stick, let's put an abrasive substance on it, and let's just scrape away the plaque twice a day. That's really all of it. That's really all we do for patients. It's kind of the same thing for hydrocephalus. Let's stick a tube in their head and have the fluid drain. That's really what we do. It's not a very sophisticated treatment, but it's a very effective treatment. The tube is called a VP shunt, or a ventriculoperitoneal shunt. If you just remember the name of the shunt, then you know everything there is to know about it. It is a catheter that is inserted in one of the ventricles, in the lateral ventricle, and then it empties into the peritoneal cavity where the lymphatics can drain it out. That excess fluid is easily removed from the peritoneal cavity. It doesn't result in any sort of clinical problems there. From time to time, you may encounter a patient like that. It'll happen, and you'll see, they'll tell you, of course, and the history will be notable for hydrocephalus. I'm not going to hide that from you. But you can see the tube right beneath the skin, and then there's a portion that goes just about from behind the ear to above the clavicle. And that is outside of the skin, and that allows the patient or their attending physician access to clean the tube and to drain it or even to replace it as needed. And then it goes beneath the skin again, and it travels subcutaneously into the peritoneal cavity. So that's one consequence. Yeah?
Will that create ascites?
Does it create ascites? So that's a good question. Does it create ascites? Does it create any sort of swelling or sequelae related to that? The amount of fluid that is actually getting delivered into the peritoneum is quite small. It's clinically significant because the ventricles are a very small space and because there is fixed structures around them. But the amount of volume that is added, the amount of liquid that's added to the peritoneum, is easily accounted for by the lymphatic system.
Also, does it have to be like regular? So like, do they have to, or is it just one time that it was like that big, and then once it drains out, or do you need multiple visits for the VP shunt?
So the VP shunt is inserted, and it's inserted in one visit, and then it belongs to the patient. It's a part of them for the rest of their lives. That shunt is a part of them, and it just needs to be regularly maintained and kept clean. Yeah. And just like a car, if a valve goes, you need to get it replaced. Another consequence, or an important consequence of increased intracranial pressure, is something that's known as herniation. Herniation simply referring to this sort of getting pushed out or squeezed out of tissue. So if intracranial pressure has increased or raised for some reason, because the patient has hydrocephalus or because of cerebral edema, the brain just needs to go somewhere. It needs to go somewhere, right? It's like when you are trying to zip up a suitcase that's overpacked. You know, depending on which direction you go with the zipper, that's the part of the suitcase where the stuff comes out, right? And it's very, very hard to get everything in your Herniation results in displacement of brain tissue past rigid dural folds or openings in the skull. So for example, the foramen magnum, or this is an example of a subfalcine herniation, a herniation right beneath the falx cerebri. There's also something that's known as a transtentorial herniation. This is a herniation that goes through the tentorium cerebellum. Herniations are not good things, and there are some significant complications of herniation. And we can perhaps invent those complications. It shouldn't be too hard to think about. We could think how it's possible that just the right, or shall we say just the wrong structure gets compressed. And if a major artery gets compressed, or if a cranial nerve gets compressed, or if the cerebral peduncles get compressed, there can be all sorts of clinically significant deficits. Anybody remember what the cerebral peduncle is? The cerebral peduncle is a portion of the midbrain, and it carries some rather important motor and sensory tracts into the pons. So if the cerebral peduncles get compressed, there can be some significant motor or sensory deficits. Of these three types of herniations, I just want to quickly point out tonsillar herniations. Tonsillar herniations can be somewhat worrisome, and they have a life-threatening possibility. And that is because when the cerebellar tonsils herniate through the foramen magnum, they can compress the brainstem. And that can result in life-threatening compression of respiratory centers and cardiac centers in the medulla. So suffice it to say, herniation is not a particularly favorable patient complication. Okay, the next category that we're going to learn about is congenital anomalies of the central nervous system. Second only to congenital anomalies of the heart in terms of their frequency. Remember that there exists this thing called the neural tube. Once upon a time, we learned about the neural tube. We learned that the neural tube is an embryonic precursor to the developing central nervous system. It means some images to the right as a reminder. Neural tube defects do account, in many cases, for the congenital central nervous system malformations. Neural tube defects include spina bifida, encephalocele, and anencephaly. These other two we maybe haven't heard of, but I'm sure we've at least heard of the word spina bifida. We will talk about all three of these things. And just as a reminder, this is certainly very much so in the realm of lay knowledge and public knowledge, but folate deficiency is a well-established risk factor for neural tube defects. And folate supplementation is particularly important during pregnancy. Spina bifida is a cleft in the vertebral column. So that's what spina bifida is. So literally spina bifida, cleft in the vertebral column. And spina bifida results because of the failure of fusion of the neural tube, right? So here's our neural plate that turns into a neural tube, and you can imagine how in one or another area there is a failure of fusion. And so this failure of neural tube fusion, it can manifest in one of three ways. And we will start with the most worst case scenario, although it's not the most common, simply for the purposes of explaining what is going on. So the most significant, the most worst, the most bad, the worst type of spina bifida is something that's known as a myelomeningocele. Myelomeningocele is when you have a cleft in the vertebral column, and through that cleft you have herniation of the meninges. So you have meninges that line the spinal canal, just like you have meninges that line the brain. You have a cleft through which the meninges herniate, as well as through which the spinal cord itself herniates. Sometimes within the cleft in the vertebral column, only the meninges herniate, and we call that a meningocele. Sometimes you have a cleft with no corresponding defect in the skin. Nothing has herniated at all, fortunately, but there is just a cleft that can be identified on imaging, perhaps incidentally. So the terms we give are myelomeningocele, meningocele, and spina bifida occulta. All three have a cleft in the vertebral column, but it just depends on what substances actually herniate through the cleft. Spina bifida is usually diagnosed prenatally during routine imaging, except in the case perhaps of spina bifida occulta, which might go undiagnosed sometimes. And individuals who have spina bifida are usually delivered via C-section or cesarean section. There is a wide range of symptoms, and we can perhaps imagine why there might be a wide range of symptoms and how there can be a possibility of different clinical findings depending upon which, if any, spinal nerves are affected. So findings including muscle weakness or physical deformity are all possible. Also urinary incontinence and constipation, depending upon to what extent the autonomic nervous system is affected. Management of spina bifida is typically surgical, as well as palliative management of any complications. And many individuals can be treated successfully with surgery. But if somebody has a neurologic deficit from their spina bifida and the spina bifida is addressed surgically, might that neurologic deficit persist? Yes. So the next of the CNS congenital anomalies is something that's known as an encephalocele. An encephalocele is basically a protrusion of the meninges in the brain through a defect in the skull, as opposed through a defect in the spinal canal. Again, these are usually diagnosed prenatally and managed with C-sections. Many of these patients can be surprisingly asymptomatic. Some individuals can have encephalocele in association with certain craniofacial syndromic deformities. And some individuals can have cranial nerve deficits or even seizures in association with their encephalocele. Management is surgical. Here's a case from Boston when I was a resident, and this is a 6-month-old female with a really, really large encephalocele that is protruding in between the eyes. And so it's really amazing if you look at the image on the top right. It's amazing what surgeons can do, you know, and the way they can help out individuals. It's really a very, very good outcome. Immediately after the surgery, I don't have any photographs. I don't know what she looked like 6 or 12 months later. But this is, if you look at the top left, it's a little bit of a gruesome image, but this is exactly what all needs to get done so that you can have an incision that is not in a cosmetically visible or a cosmetically sensitive area. The two images, lower left and lower right, these are microscopic images. And what we have on the right, you can just take my word for it and you don't need to know it, but that's brain. That's brain tissue that is herniated through the nose, essentially. The last of our CNS anomalies is something that's known as an anencephaly. And as the name suggests, this is absence of most of the brain as well as the calvario bones. This is because of some kind of problem with the anterior end of the neural tube. This is not a particularly common congenital anomaly. Most individuals do not even survive pregnancy. Those who do are stillborn at the time of delivery, or they die shortly after birth. Oh yeah, and we'll also mention something that's known as agenesis of the corpus callosum. So we know what the corpus callosum is, right? It's white matter, and it's white matter that connects the left and the right cerebral hemispheres. And some individuals can have a partially or a totally undeveloped corpus callosum. And it's actually interesting, agenesis of the corpus callosum can have a variety of clinical findings. It can, believe it or not, be totally asymptomatic sometimes, especially if there is some mild connection between the left and the right cerebral hemispheres. There can also be significant symptoms such as seizures and impaired mental and physical development. This is a condition that is usually not fatal, and so treatment is supportive or palliative, attempting to address whatever underlying issues there are, such as hydrocephalus, which we've already learned about, or seizures, which we'll learn about soon enough. Seizures, so important, we're going to spend 3 minutes on them. One last anomaly that I want to introduce is something that's simply known as holoprosencephaly, right? We all know our Cyclops from our Greek mythology or whatever kinds of stories. And Cyclops is a worst case, grammar is terrific today. It is a very, very severe type of holoprosencephaly. Holoprosencephaly is a whole spectrum of malformations that is characterized by an incomplete separation of the left and the right cerebral lobes. Worst case scenarios have only one lobe in the brain and one single eye that's right between where the two eyes should be. Some cases can be extremely, extremely mild, and they manifest only as a median cleft. Remember, once upon a time, we learned about cleft palates and cleft lips, how they're lateral. You can have a median cleft lip, or sometimes you can have a patient with only one central incisor, and that can be a very, very mild manifestation of holoprosencephaly. Oh, okay. The anomalies just keep on going. Okay, 2 more. About this one. So the next malformation, the next anomalies we'll learn about is something that's known Chiari malformations. Chiari malformations are a setting of 3 or 4 different syndromic presentations that are a result of a small or a misshaped calvarium. And so because of the decrease in size of the calvarium, there is a somewhat increased risk of tonsillar herniation, right? We just learned about tonsillar herniations a second ago. Not all individuals have tonsillar herniations, but clinical symptoms can be variable depending upon the degree or the risk of herniation. Some patients only have neck pain, and some patients have hydrocephalus, and more significant consequences include motor and sensory deficits, blurred vision perhaps, even risk of death because of difficulty breathing or cardiac arrest. Chiari malformations, particularly Chiari 2 malformations, these can be accompanied by spinal myomeningoceles. Management is typically symptomatic. Sometimes there's a role for neurosurgical intervention, but most people, particularly if there's not significant risk of tonsillar herniation, they're just managed with pain medications. And if there is some amount of hydrocephalus, then a BP shunt is inserted as well. So these are Chiari malformations. This is a constellation of 3 or 4 malformations that are a result of a small or a misshaped calvarium that just does not leave enough room for the cerebellum to be where it wants to normally be. Cerebral palsy is, I suppose, less of a congenital anomaly than it is a developmental problem. Cerebral palsy is a condition that is associated with low birth weight, particularly in a preterm setting, and other risk factors are less well understood. How exactly this condition arises is not entirely understood, but clearly it has something to do with cerebral insults that arise both during the prenatal period and during the perinatal period. Or I should say or, really either or. And this has a permanent effect on brain development as well as sometimes physical development as well, because damage to the central nervous system can result in all sorts of motor deficits. Individuals with cerebral palsy from a young age, they can exhibit spasticity and dystonia. These are these involuntary and spastic muscle contractions. Some of them have a total loss of coordination, total or partial loss of coordination. And this inability to coordinate muscular movements also includes speaking, right? Our tongue, our lips, those are muscles. Individuals can have muscular weakness as well. So perhaps we've seen images of cerebral palsy, children with cerebral palsy, and they need a walker, or sometimes they're even wheelchair bound. They have difficulty walking. And this is because some sort of cerebral insult happened early on during brain development. There's no cure for cerebral palsy. Management is symptomatic over the course of an individual's life, but it usually does not shorten or arrest the lifespan. Any questions about the diseases we've talked about so far? We're probably already behind. We're like on slide 12 or something. Okay, let's quickly talk about a couple of examples of CNS trauma. And so examples of trauma to the central nervous system, or example of trauma to the head, include skull fractures, which we're not going to talk about at all, and also parenchymal injury and vascular injury. So for parenchymal injury, think concussion, which we'll spend like 12 seconds on today, and vascular injury. So we'll learn about some hematomas, right? Epidural hematomas, subdural hematomas. Remember, the brain has a limited capacity for functional repair. And so that is why there's always a big amount of risk to central nervous system damage. Also keep in mind that where trauma occurs has a significant influence on what the clinical symptoms are. Trauma can occur in an area that results in a totally asymptomatic disease course, or it can be severely disabling, as in the case of paralysis following a motor vehicle accident, or if there's injury to the brainstem, it can be totally fatal, because that's where the respiratory and cardiac centers are. Since we won't talk about skull fractures at all, I only want to point out that basal skull fractures can present with the so-called raccoon sign or panda eyes. And that's all. That's just a little factoid. You can bring that up on a date if there's nothing to talk about. The conversation is dry. And here's a panda. Here's a panda right here. So my wife and I, we were in Thailand in February. We were lecturing and we went and visited the Thailand Zoo, and they've got 2 pandas, and these are very hardworking animals. But I've learned a lot about pandas. Did you know that pandas in the wild they only live in China. And so China has complete control over this natural resource. Just like countries in the Middle East have complete control over their natural resource, which is gas, or oil. Whatever we call it, natural gas. But, so these panda bears are property of China. And if Mr. Panda and Mrs. Panda, who belong to China, they have baby panda is property of China. And Thailand needs to pay a baby tax to China for the privilege of having created this tourist attraction of a baby panda. It's really amazing. In years past, China engaged in panda diplomacy. They would give pandas to different countries as part of foreign diplomacy relations, but they no longer do that. They now have tighter control over their natural resources. So that's panda. That won't be on the test. Concussion, we'll talk about in 15 seconds. Concussion is a clinical presentation of altered consciousness. The concussions happen secondary to head injury. Concussions are characterized by a very acute, by basically an instantaneous onset of neurologic dysfunction. And the neurologic dysfunction can present a couple of different ways. Entire loss of consciousness, amnesia to an event, loss of reflexes, and even transient respiratory arrest. This can all be seen in the setting of concussions. Concussions are managed by rest alone. And that's why, for those of you in the room who follow sports, there's a certain period of rest that an athlete needs to wait through before that athlete is allowed to participate in sports again. And every so often you see or hear reports about how a physician is testing athletes' reflexes on the sideline to see if they can get back into the game, and most honest researchers acknowledge this is like totally a fake thing, because every athlete wants to get back into the game and they're just gonna say yeah, and then they go back. And so that's sort of an active area of discussion. How can we actually best take care of our athletes who have just had concussions?
What causes with concussions, like sensitivity to light?
Sensitivity to light? The sensitivity to light represents damage to the optic nerve. So the optic nerve, which innervates the retina, if the optic nerve has in some way been damaged because the whole cerebrum has, for example, moved backward because Muhammad Ali punched you, then you're just going to have, that's going to be sort of a sensory paresthesia. You have a sensory paresthesia somewhere else, then it's going to manifest as tingling. You have it in the optic nerve, it's going to manifest as light sensitivity. We're going to learn about epidural and subdural hematomas. So direct trauma to the head can result in skull fracture, it can result in concussions. It can also result in disruption to a vessel, which can lead to hemorrhage, which can be quite clinically significant, because remember, the skull is an enclosed space. So if you open up a vessel and allow it to start pouring blood into this enclosed space, you can have a risk for a lot of things, such as herniation of some sort. Hematomas can be epidural or subdural, and there's a useful cartoon on the top right, and it basically refers to the location of the hematoma relative to the dural matter. Epidural hematomas result from rupture to dural arteries, such as the middle meningeal artery. These enlarge very, very quickly. They can compress the brain surface. These are neurosurgical emergencies, and about 5, 10, or 15% of patients die from within the first hour if they are not treated adequately and urgently. Subdural hematomas occur beneath the dura mater. Technically, they occur within the 2 layers of the dura mater. There's 2 layers of the dura mater. Subdural hematomas occur because of trauma affecting the bridging veins. And these are somewhat frequent in infants. By somewhat, I mean really in a relative sense, relative to the other age ranges. Subdural hematomas have slowly evolving neurological symptoms, unlike the clinical picture of an epidural hematoma. But subdural hematomas also require emergent neurosurgical management. As many as 50% or more of patients die from subdural hematomas. I had a classmate in middle school whose father died from a subdural hematoma. He fell down the stairs and no one else was at home.
But why is it that infants are more susceptible? So they're more likely to have the subdural versus the epidural? Or
The reason why is twofold in infants. These veins are very sort of tender. The dura mater is actually the same thickness and consistency see all throughout life. But the calvareal bones are less well formed, they're softer. Infants are also rambling around and running into doors and these kinds of things. Maybe we've heard of CTE, or some of us have heard of CTE. For anyone who hasn't, there's a very good movie that's a few years old now, Concussion. Super, super interesting movie. It's a true story of this physician who identified and discovered this particular condition, who happened to be the attending physician at the time of deaths of a few football players in the Pittsburgh Steelers football team. Really, really, has anyone seen this movie? It's worth seeing, it's worth seeing. So the weekend's here, so I want you to know. So CTE, this condition, chronic traumatic encephalopathy, is basically a neurodegenerative disease. It's a chronic disease that is characterized by a history of multiple chronic concussion-like episodes of the brain earlier on in life. So for example, when you were a football player during your active years. The head trauma, at this point, it's still not clear if it is the severity of the head trauma or the frequency of the head trauma that is really the critical cause for CTE. Some football players get CTE, but not all do. There's a variety of clinical presentations to CTE, some of which are rather striking. And these include Parkinsonism, whatever that word means, Parkinsonism. For now, I'll simply say that it is a constellation of signs and symptoms that are seen in Parkinson's disease, but can also be seen in other diseases that have a similar pathophysiology to Parkinson's disease. There's cognitive impairment, and in the cases of these football players who were index cases for the discovery of the disease, depressive and suicidal thoughts, ultimately leading to suicide in worst case scenario. There can be striking behavioral and personality changes, kind of like mad cow disease, which we'll also spend 3 seconds talking. I really won't say anything about spinal cord injury because I'm sure I'm very far behind in the lecture already, but spinal cord injury is extremely straightforward in terms of just some abstract points that we're going to make. We're not going to learn about spinal cord injury in any level of detail. But basically a traumatic event to the spinal cord can result in transient or permanent damage to the vertebral column as well as to the spinal cord itself. If the spinal cord is in some way disrupted or impaired, there can be permanent damage distal to the spinal canal, and there can be permanent motor and sensory deficits. If there is a very, very serious accident involving the spinal canal, of course, depending upon where the accident occurs and which vertebra have been affected, there can be different levels or different extent of paralysis. Okay. Any questions? Okay, so let us talk about stroke. Stroke, this condition that we mentioned ever so briefly when we were thinking about possible examples of acute injuries to neurons. When we were thinking about acute examples of hypoxia. Stroke, which is really the term for cerebrovascular disease, is a common cause of death in this country. And some people include it within cardiovascular disease, and some people consider it to be a separate category. Cerebrovascular disease is cardiovascular disease occurring in the brain. So everything that we've already learned about cardiovascular disease, everything that we've learned about thrombosis and thromboembolism applies here. There are really no new concepts. Just some anatomic considerations to take in mind, such as the fact that neurons do not replicate, and neurons are very sensitive to changes in oxygen saturation of blood. Among neurologic diseases, which is all the diseases we're learning about today, strokes are one of the most common ones in terms of morbidity and mortality. The brain, keep in mind, is extremely sensitive to alterations in blood supply. And that's because it consumes a tremendous amount of the body's oxygen for its normal functions. It also does not use anaerobic glycolysis at all, and really is dependent on oxidative phosphorylation in the setting of high levels of oxygen consumption. Neurons cannot live for long at all in the absence of oxygen. That's why, what is the mnemonic for strokes? You know, you see the billboards, and what's the mnemonic for stroke? Think what? Think fast. You need to think fast, because the neurons don't last very long at all. And the longer you wait, the more permanent damage your patient will have. You all will have patients with stroke, and you all will see that some of them have a complete recovery and some of them don't. It's largely related to the timing of treatment. Cerebrovascular disease, before we get into sort of our classic stroke episode, which we'll talk about very briefly, I just want to point out that cerebrovascular disease can be generalized or it can be focal. Generalized cerebrovascular disease, or global cerebral ischemia, can result in conditions such as if there is cardiac arrest or if there's extreme hypotension. There's just not enough blood, there's not enough oxygenated blood getting to the central nervous system. And one example that we gave in the beginning of the lecture was what? What was one example of general cerebral ischemia or global cerebral ischemia?
Herniation.
Not so much herniation, not so much herniation. But we're thinking about atherosclerosis, and we're thinking about atherosclerosis involving which vessels? The carotid and the internal carotid. And so we were thinking about possible therapeutic approaches. Maybe you need to go in there, surgeon needs to go in there and strip the vessels and clean them and suture the vessels back up. And that actually is a procedure that's done, endarterectomy. Cerebral ischemia can be focal as well, and that is certainly much more what we think of when we think about strokes. And so focal cerebral ischemia occurs in a variety of settings, all of which should make sense. If there's a cardiac neural thrombus, let's say that there is a blood clot in the heart because of a previous myocardial infarction, if that embolizes and goes to the brain, then that causes very, very important sequelae in the brain. Myocardial infarction itself can result in a stroke-like episode. Valvular disease can contribute to thromboembolism. Atrial fibrillation. It's very important to know that individuals with atrial fibrillation are at increased risk of stroke. You will see this all of the time in your patients. Your patients are on atrial fibrillation and they're on a blood thinner. The reason why they're on a blood thinner is because their heart is irregularly beating and does not successfully pump all of the blood out of the right ventricle. And some of that blood remains stagnant. And so what happens to that stagnant blood?
From the impulse.
It clots, it coagulates, right? We've learned about our three main contributing features to coagulation. It clots. And so what might happen if one of those times during an irregular heartbeat, that whole clot actually does dislodge or a part of it does? Where might it travel to? Brain. So this is why individuals with atrial fibrillation are on blood thinners. You will see this frequently. And of course, atherosclerosis with all of its sequelae can result in stroke. Strokes can be hemorrhagic or they can be thromboembolic. Hemorrhagic strokes are strokes that are usually seen in the setting of hypertension. So remember, strokes are clinically significant because distal to some area of vascular damage, there is tissue ischemia and tissue infarction, which has significant clinical sequelae because neurons don't last very long on their own. And so it makes plenty of sense to think about how if a blood clot travels to a certain vessel in the brain, then you will have tissue ischemia distant to that vessel. But if you have a laceration in that vessel, or if that vessel bursts, for lack of a better word, in the setting of hypertension, you are still going to get tissue ischemia distal to that bursting. You will get what's called a hemorrhagic stroke because that vessel is ruptured and so it's just bleeding into the brain. But all of that tissue that is depending upon that vessel for nutrients and oxygenation is not getting the blood that it needs to survive. And so strokes can be hemorrhagic, and those will occur in the setting of hypertension. Individuals who have malignant hypertension, what is malignant hypertension?
Higher than 160.
So not 160. 160 is a very careful range that we use in this dental school, and it's fine that we use that range, but it's a very careful range that we use in the dental school, above which we're not going to treat our patients. But patients with a blood pressure of 160 and over 100, they're not yet in the state of hypertensive urgency. Malignant hypertension is really closer to what blood pressure? It's closer to 180 or 200 over 120, yeah. These are extremely, extremely high blood pressure. It's called hypertensive urgency, or a more outdated term, which I see I've included, malignant hypertension, because these individuals are at very, very high risk of a hemorrhagic stroke, basically a pipe bursting. The same way a pipe may burst at home if the pressure is too high. This is basically a pipe bursting in the brain because the pressure is too high.
So it would be 180 over.
I'd say at any blood pressure, 180 or above, it is worth asking the patient a few questions. And the questions that you'll ask the patient are, do you have any headaches? Do you feel dazed or confused? Do you feel nauseous or vomiting? And that's because very, very, very high blood pressure, especially if it is causing a hemorrhagic stroke, it can result in these kinds of clinical presentations. So you are wise to ask, you're more than wise, you're doing the correct thing if in the setting of very, very high blood pressure, in addition to discontinuing dental treatment, or I should say not beginning dental treatment, you should do more than send the patient home. You need to quickly assess them and see that if you need to offer them a ride to the emergency department or not.
Do you know how commonly, because I know here in dental school we always check blood pressure, but I have never had my blood pressure checked at the dental office outside of this school. Is that something that private practices do at all?
I think there's at least one or two reasons why it happens. I don't think it occurs as frequently in private practice, the so-called real world, as it does in dental school. And I think it happens for two reasons. One reason is, if we're honest with ourselves, I think we need to concede that we actually don't know this material as well as we should once we leave dental school. We forget it. We just kind of forget it. The other thing is, we have as a profession, I would say that we have largely chosen to practice exclusively in healthy and wealthy areas of the country. And so in healthy and wealthy areas of the country, it's going to be unlikely that we encounter these kind of problems to the same extent as if we practiced in truly a demographic neutral part of the country. And so I think there's a little bit of a confluence of a couple of reasons why it doesn't happen as much, and why also you don't have really, really stunning sequelae of it not being performed on a regular basis. So it's a good question. It's kind of one of those thought-provoking questions in terms of what are all the factors that are in play. One particular type of infarct, one particular type of hemorrhagic infarct I want to talk about is a lacunar infarct. Lacunar comes from the word lacuna, which means lake-like. Lacunar infarcts, which account for up to a quarter of all strokes, these are really, really small infarcts, really not more than a centimeter or a centimeter and a half in size, that are caused by occlusion of a deeply penetrating branch of a large cerebral artery. Depending upon where this occlusion occurs, it can be clinically silent, and it frequently is, or it can have some significant neurologic impairment if it affects some motor sensory pathway. I'm saying hypertension and hemorrhagic strokes. When I say hypertension, when I say lacunar infarcts occurring in the setting of hypertension, I'm referring to the fact that in the setting of high blood pressure, small arterioles will compensate by marked thickening of the muscular layer, the tunica media. And so this layer markedly thickens to control the blood pressure. Remember, blood pressure is controlled at the arteriolar level. So all of this blood that is flowing in very, very quickly, the arterioles need to sort of contain that, and then let the blood flow through the capillaries at their normal pace. And so a tremendous muscular layer around the arterioles can develop, so much so that, just like, a person who's so muscular they can't put their arms down, this muscular layer can become so large it can actually significantly occlude the lumen of the arteriole. If a blood clot occurs in that area because of some kind of damage to the endothelial layer, or because of cholesterol plaque that is ripped off there, if a blood clot forms, a medication is known as alteplase, which is recombinant TPA. What does TPA stand for? Yeah, so plasminogen activator. So how does plasminogen activator work? So it works by activating plasminogen. And plasminogen is a precursor to plasmin, which breaks down clots. It plays an important role in fibrinolysis. So if a clot has developed in an area, if that clot is still soluble enough that you don't have that tough fibrin network that's insoluble that deposits, about 4 to 5 hours after blood clot forms. If you get to that clot first, you can melt it away or bust it away with TPA. So with regards to hemorrhagic strokes, high blood pressure is the main risk factor. As a matter of fact, chronically hypertensive individuals, about 15% of them die because of hemorrhagic strokes. Another risk factor for hemorrhagic strokes is cerebral amyloid angiopathy. Now that's some 3 rather peculiar words, but if you actually just read them and you take a deep breath, you know exactly what's going on. There's damage to vessels in the brain because of deposition of amyloid. And we will soon enough, we will learn about Alzheimer's disease. We will learn that Alzheimer's disease is a disease of amyloid. Alzheimer A, amyloid A. So we remember what an aneurysm is. An aneurysm is a little outpouching, a pathologic outpouching in a vessel. There exist buried aneurysms or saccular aneurysms that are actually rather common within the circle of Willis. 1 to 2% of the population has buried aneurysms in the circle of Willis. The reason why I'm mentioning them here is first because they're common, and secondly because 1 to 1.5% of buried aneurysms rupture annually. It's like a super high percentage. Buried aneurysms have a fairly characteristic clinical presentation. The clinical presentation is that of an excruciating headache of sudden onset, which can be described by a patient as the worst headache I've ever had. They're actually only described by the patient that way if they survive the episode. As many as half of patients who have rupture of a buried aneurysm die from that cause. If you don't die, you recover within minutes. Patients, of course, need to be admitted to the ICU for continuous monitoring in the minutes, hours, and even days following a buried aneurysm to ensure complete recovery. Individuals need to engage in more restful activities, and there are some drugs as well that work, although the mechanism of action isn't entirely clear. But buried aneurysms, worth knowing because they're common, because they rupture relatively commonly, because they have a really striking clinical presentation, because they can cause death. So what are clinical features of stroke, whether it's hemorrhagic or whether it's a thrombotic stroke, which we really haven't gone into the pathophysiology too much because we've covered it extensively in our cerebrovascular, in our cardiovascular modules, and in our thromboembolic modules. So we think about our little mnemonic FAST, and the reason why we educate our population, the lay population, with these kinds of billboards, is because of sensory or motor deficits, including speech deficits, that happen very, very quickly upon the onset of ischemia, and they need to be treated very, very quickly to minimize permanent brain damage. The manifestations of a stroke vary depending upon what part of the brain is affected. That should make perfect sense. And so symptoms can vary from lightheadedness and dizziness to difficulty walking and speaking to entire paralysis or numbness of one extremity or one half of the body. Strokes are medical emergencies. In individuals who have blood clots, early treatment of TPA can minimize permanent brain damage by quickly restoring blood flow to the distal portion of the obstructed artery.
So the TPA breaks up the blood clot?
That's exactly what it does. So TPA, that is pharmacologic administration of exogenous plasminogen activator. And remember with blood clots, we learned about our primary and our secondary hemostasis. Then we learned about how once that fibrin meshwork develops, those clots are very rigid and durable. But in the first few hours before that insoluble fibrin mesh has developed, you have a clot that is soluble, and then in the presence of plasminogen will actually quickly dissolve. You will have patients who will tell you that they had a mini stroke and that everything's fine. And it's probably true that everything is fine, but for starters, you need to know what a mini stroke is. A mini stroke is a transient ischemic attack, TIA. This is a stroke-like attack that resolves quickly. While it's happening, you have no idea that it's stroke-like and that it's a TIA. And so your individual who tells you that they had a TIA, while they were having it, they didn't know that. They were being rushed to the hospital because they were having a stroke-like presentation. But some occlusions are temporary and they self-resolve. And so the clinical presentation of weakness or numbness and paralysis, it transiently lasts and goes away quickly on its own. These individuals carry a very small risk of permanent brain damage, although they obviously represent an at-risk population for whatever reason, because of their lifestyle habits or because of their comorbidities and the presence of cardiovascular disease they have elsewhere. Some patients with TIAs will be on anticoagulants, and of course they need treatment of their underlying arteriosclerosis and pulmonary disease, and these would be good patients to engage in healthy lifestyle changes. Speaking of healthy lifestyle changes, this is when dinosaurs became extinct. We will very quickly learn about infections. With infections, there's not too much to say. We're really just going to talk a little bit about meningitis. There's a few different routes by which infectious agents can enter. Oh my gosh, it is so late. Let's take a 10-minute break here. We'll start in 10 minutes, okay? Y'all are very late. Oh my god, we're not even halfway through. Infections can arise by direct implantation, which I don't think we'll talk about at all. Those can be associated with trauma or the result of some kind of iatrogenic process. Infections can result from local extension. You've probably all encountered horror stories of some tooth infection that resulted in a brain abscess. And infections can occur via local extension from peripheral nerves. What might be an example of a disease we've already covered, where infection arises via local extension from peripheral nerves? And there is a diffuse state of muscular tetany. Tetanus. Tetanus, very good. We know so. But let's talk a little bit about meningitis. Meningitis is inflammation of the leptomeninges, so not including the dura mater. The leptomeninges are the arachnoid matter. I'll also introduce this term, meningoencephalitis. That's basically meningitis, including primary inflammation of the encephalus, the brain rings. Meningitis reclassified into acute pyogenic. That's essentially a bacterial meningitis that results in a purulent inflammatory response. Aseptic meningitis can be viral. Meningitis can also be chronic in the setting of tuberculosis or cryptococcal infection. As a matter of fact, cryptococcal meningitis, which we've learned about before, and I'll just mention in passing, is actually a fairly significant cause of death in AIDS. And it can be quite aggressive. Individuals can die of this disease in a matter of a couple of weeks. Most common meningitis is bacterial or acute pyogenic. It is caused by distinct microorganisms in distinct age groups. And I'll just point out that in adolescents and young adults, Neisseria meningititis is a common cause for meningitis. It's the most common cause. Now, as a matter of fact, from time to time you hear about sporadic outbreaks in dorms or in military living quarters. And that's because usually of Neisseria meningititis. Symptoms of meningitis are kind of what we all think of. Maybe neck stiffness, that's exactly the case. And also some head-related symptoms, headache, sensitivity to light, sort of a clouding of consciousness or a fogginess to one's consciousness, and irritability. There may be constitutional signs of infections like fever, weakness, malaise. Diagnosis of meningitis is usually via a spinal tap, and I have a little cartoon here on the right. You literally do need to tap on cerebrospinal fluid, and then you need to test it to see what microorganisms are there and what inflammatory response is present. Meningitis is usually treated via medications. If it's untreated, it can be fatal. We will encounter Waterhouse-Friedrichs syndrome one more time in our endo lectures, and I'll just mention it here as well. It's important to mention here because Waterhouse-Friedrichs syndrome, did I pronounce it correctly this time? This particular syndrome, it results almost always from septicemia in the context of meningitis. We'll learn about it again in our endo lecture because this septicemia results in shock and disseminated intravascular coagulation and very frequently involves the adrenal glands, such that adrenal insufficiency occurs, whatever adrenal insufficiency is. And maybe we can think about what that is when we think about what is secreted by the adrenal glands. So that's meningitis, really only talking about bacterial meningitis, and keeping in mind that Neisseria bacteria meningitis is the common cause of meningitis in this particular age range, adult age. What is a brain abscess? A brain abscess is an abscess that happens in the brain. Usually a brain abscess is because of a bacterial infection, and it can be a result of direct implantation of some organism iatrogenically, or it can be local extension from some other source. That other source usually not being a tooth, although we're dentists and we're taught all about the teeth. Usually brain abscesses are in the context, when they are in the context of local extension, it's for mastoiditis or sinusitis. Sometimes it can be direct, or perhaps instead of saying direct, I could say hematogenous, but perhaps it can be because of a dental infection that retrograde travels into the central nervous system. Brain abscesses are usually fairly destructive lesions. They have progressive and rapidly advancing neurologic deficits. With surgery and antibiotic treatment, the mortality rate is low, but without, the mortality rate is high. Have we all learned about Diamante Driver? Have we learned about Diamante Driver? I'm sure that'll be a case study at some point in your 4 years. But Diamante Driver was I think a middle school aged child who was not able to get access to dental care. He had some dental cavity, or he had some root canal and some tooth, and he wasn't able to get treatment because when he presented to a few different dentists, he could only pay his treatment with Medicaid, and the dentist didn't accept Medicaid. And so his infection continued to spread until he had a brain abscess, and I think he died from his brain abscess. If you Google or Wikipedia Diamante Driver, you'll get the exact history. I forget it now. One interesting, although entirely uncommon disease is polio, poliomyelitis. This is a disease that largely does not exist anymore, courtesy of vaccinations. It still is present in some portions of the world, some very small portions of the world. Poliomyelitis is an infection that is most notable for its central nervous system features, but that is an uncommon manifestation of the disease. Usually infection with poliovirus is entirely subclinical, or at most there are mild GI symptoms. On occasion, the central nervous system is affected, and when the central nervous system is affected, usually its involvement is limited to meningitis, which the patient recovers from. In rare cases, when the central nervous system is involved, involvement can advance to include the spinal cord, in which case we have our characteristic presentation that we think of. What U.S. president had poliovirus?
Roosevelt.
Yeah. Might have been FDR. It was Roosevelt. Yeah. It's that guy. Can somebody look up? That way we should know this. I should know this. One of our presidents had poliovirus. And so these very characteristic. It's FDR? Okay. So FDR, Franklin Delano Roosevelt, had poliovirus. And the poliovirus that he had and that others can have, and they have most extensive consequences of the disease, are a paralysis that occurs when motor neurons are affected by the virus. And so there is an increasing paralysis, a so-called flaccid paralysis. That is, the muscles are totally limp. There's no muscular tone to them. A flaccid paralysis with progressive muscle wasting and loss of reflexes. When the disease continues to progress to involve respiratory muscles, then death can be close. Some individuals have an entirely different clinical picture of CNS involvement, and that is something that's known as post-polio syndrome, which occurs some 30 years or so after complete resolution of the initial illness with no significant sequelae. And that is progressive muscle weakness or pain without any serologic evidence of viral reactivation. Another infection we'll learn about is rabies. Rabies is something we've all heard of. And rabies essentially is a severe encephalitis that is transmitted by the bite of an animal that is rabid, that is, an animal that does have rabies. Rabies enters the central nervous system over a 1 to 3 month period by slowly ascending via peripheral nerves in a retrograde fashion. There's an incubation period of 1 to 3 months, depending upon where the bite occurred, how close that is to the central nervous system, and how rich vascularity is as well. Vaccination prevents infection. Vaccination can also be given immediately following exposure. If that does not occur, and if disease is untreated, the disease course is usually fatal. And once symptoms begin to appear, there's not a lot of time left in that individual's life. Symptoms begin as malaise and headache and fever, and they can progress to sensory deficits around the wound, and ultimately violent motor contractions, convulsions, that foaming of the mouth that we have seen pictures of, at least with animals. Death frequently arises from respiratory failure. I'll just point out, there's a large chart here, which we won't go through in any detail, but I'll just point out the prognosis is poor in untreated patients. With rabies, really survival is exceptionally rare. But with proper wound care and proper post-exposure prophylaxis, most individuals, if not all, will do very well. Let's learn about prion diseases. Do we know any prion diseases? The best example is mad cow disease. Have we heard of mad cow disease? So mad cow disease is a prion disease. But just as a quick introduction, prion disease is a disease of prions. A prion is an abnormal prion protein. We normally have prion proteins in many cell types, but most notably in our derma. And what exactly is the function of a prion protein? I'm not entirely sure, but I think it has something to do with memory. But a prion is an abnormally folded, it's a misfolded prion protein. And this misfolded prion protein has undergone some sort of a conformational change in its shape that renders it resistant to enzymatic digestion. And so this abnormal, this mutated prion, it accumulates within neural tissue, eventually leading to the death of the neural tissue. Prions also have a domino effect. That is, a prion will facilitate a conformational change of a neighboring prion protein into a prion. This results clinically in rapidly progressive signs and symptoms. Before we learn about mad cow disease, which is variant CJD, let's first learn about CJD, which is Creutzfeldt Jakob disease. This is the most common prion disease. Just because it's the most common prion disease doesn't mean it's common at all in terms of human diseases. It has very, very uncommon incidence. Usually it occurs sporadically in the background of mutational changes to prion protein that may occur at an extremely low rate in all of us, but for some reasons occur more rapidly in patients who develop the disease. About 10% of cases are familial, and you might be able to guess that there's a gene that's responsible for that protein. If the gene is mutated in such a way, it predisposes to this disease. CJD manifests as a very rapidly progressive dementia with an incidence in the 7th decade and only a few months of life after the disease has come to clinical attention. This is unlike variant CJD, which usually affects young adults, in which case, and where the dementia progresses more slowly, although it is also ultimately fatal. Variant CJD, importantly, is characterized by prominent behavioral changes. Look at how behaviorally changed these cows are. Variant CJD is caused by ingesting food from livestock that has active prion disease, and that prion disease being BSE, or bovine spongiform encephalopathy. So variant CJD is closely related to mad cow disease. Do any of us remember when mad cow disease was going on in the UK? It's like in the mid-90s.
I was there.
You were there?
Yeah, so I can't give blood.
Okay.
Yeah, I might still have this.
Wow, I think you're doing okay. Not have lunch with her. Okay, so what's a seizure and what is epilepsy? That's going to be our goal over the next 25 seconds, covering seizures and epilepsy. So a seizure is a sudden and uncontrolled electrical disturbance in the brain. By electrical disturbance, I'm referring to the conduction of impulses via neurons and neuronal networks. This change, this abnormality in electrical conduction, it manifests as behavioral changes or in changes in movements or changes in feelings. It can even result in changes in consciousness. Seizures happen acutely. They last for a finite period of time, and in between seizures, patients have no symptoms whatsoever. Epilepsy is recurrent unprovoked seizures. About 1% of the population has epilepsy. You will have patients with epilepsy. What exactly is an unprovoked seizure and what counts as a provoked seizure? We'll get to that in just a minute. But epilepsy is almost by definition an idiopathic condition. These are unprovoked seizures that are recurrent. Seizures are a different variant, are a different severity, and they can have different signs and symptoms depending upon how much of the brain is involved. Seizures can be generalized, in which case they affect both sides of the brain. And common generalized seizures include petit mal and grand mal seizures. Petit mal seizures, also known as absent seizures, are really characterized by a few moments of absence, just sort of blinking off into space and just staring and being disconnected for a few seconds. Now, we all do this very routinely, especially when someone is lecturing, but some people do it when they actually have a petit mal seizure. Petit mal seizures are in contrast to grand mal seizures, which are quite significant. And these are characterized by muscle spasms and jerks, falling to the ground, even loss of consciousness. Usually following a grand mal seizure, a person feels very tired. Focal seizures or partial seizures affect just one area of the brain. And they can be simple in that they just result in a little bit of twitching or a peculiar sensory change in sensation. They can result in more complex features like confusion and unable to respond to questions for a few minutes. Sometimes a focal seizure can trigger a generalized seizure, such as a petit mal or a grand mal seizure. Not all seizures are emergencies. Not all seizures are emergencies. If somebody is having a seizure in your dental office or in your dental chair, you call 911 if the seizure is still going on after 5 minutes. If someone has a seizure in your office, you don't start crying and calling mom or dad. You wait 5 minutes. You make sure the patient is comfortable. You make sure the patient is well cushioned. And then you expect that seizure, you confidently expect that seizure to resolve within a few minutes. If the seizure still lasts after 5 minutes, you have your front office assistant who's ready, and at 5 minutes they're ready to call the ambulance. Let's return, now that we've learned some basics, some very quick basics in 10 seconds about seizure presentations, to seizures and epilepsy. So seizures are acute and they're symptomatic. Usually seizures occur in the setting of an acute medical condition. Think a stroke. If a stroke, for example, affects a critical portion of a neuron communicatory network, it can trigger a seizure. Traumatic bone injuries and even some infections, these can all result in seizures. So it's not uncommon for someone with an acute neurological condition to have that presentation, to have a superimposed seizure over it. Individuals who have seizures in this kind of a setting may have a few recurrences during the disease course of the index or underlying illness, but generally they have a low risk of epilepsy. Remember, epilepsy refers to seizures that are recurrent and that are unprovoked. Unprovoked and of unknown etiology. We do also use the word seizure to refer to, we do also use the word epilepsy to refer to seizures that are recurrent in the setting of some underlying brain condition that we cannot address. If somebody has progressive Parkinson's disease, or if somebody has had a stroke, and if for the rest of their life they are at risk of getting seizures, we go ahead and call that epilepsy, and we just annotate the epilepsy as secondary to whichever neurologic condition. But many individuals do not have an underlying condition that triggers their epilepsy. They'll tell you they have epilepsy, they'll tell you they get seizures, you'll ask them when do you get seizures, and they say when I don't take my medications. I've listed the statistics here for the sake of time. I won't read through the statistics, but seizures do occur, epilepsy does occur. You will have patients with seizures and epilepsy. We'll segue a little bit to demyelinating diseases. We've already learned about one demyelinating disease. We've learned about Guillain-Barré syndrome. We'll learn about another one or two here. Demyelinating diseases, if we remember learning about neuropathies and demyelinating neuropathies, these are diseases that are characterized by preferential damage to the myelin sheath. The axon itself is preserved, but there's still progressive motor and sensory deficits because the myelin sheath plays such a critical role in transmitting electrical impulses. Many conditions can cause loss of myelin, such as multiple sclerosis, which is really the most important index disease that we will talk about. Clinical deficits arise and clinical deficits are progressive because the CNS has a limited capacity to regenerate myelin. We'll get to that in a little bit more detail when we talk about multiple sclerosis. Here's just a reminder of myelin sheath and cell bodies in gray matter and white matter. You all are learning all about it, right? Multiple sclerosis is a very interesting and interestingly named disease. It's named after its appearance on MRI. MRI is the single most important test for multiple sclerosis, both diagnostically as well as prognostically. And on MRI, within the central nervous system, whether it's the brain or the spinal canal, you have, as the name guesses, you have multiple densely sclerotic lesions. That's why it's called multiple sclerosis. And depending upon where those lesions are and where new lesions develop, you have a specific clinical presentation. Clinical presentation and progressive nature of the disease varies extremely widely from patient to patient. MS is the most prevalent chronic inflammatory disorder of the central nervous system. We would love to call it an autoimmune disease, and maybe it is, but it's not really proof yet to call that yet. MS is about 1 in 1,000 individuals. You all will encounter people with MS. It's usually middle-aged women. MS has a relapsing clinical course that is ultimately progressive. It's characterized by distinct episodes of days to weeks that are symptomatic, and in between episodes, you have periods of variable recovery. Either you will recover fully to your pre-episodic state, or you will have partial recovery with a new episode of disease, and then again in complete recovery with gradual deterioration. But episodes are characterized by unilateral visual impairment, that is if one of the optic nerves is involved, limb weakness, sensory loss, double vision, and even loss of coordination if you have cerebellar lesions. I've just listed a few here, but really a variety of findings can occur, a variety of clinical signs and symptoms can occur during an acute episode. Everything's rather complicated in terms of how this disease develops, and it's poorly understood, so look at this picture really only if you're having trouble sleeping at night. But I do want to draw our attention to the 3 images on the right and say that after an acute episode, there are 3 potential sequelae. Inflammation can entirely resolve without remyelination. So you can have a chronic inactive episode. So the episode has ended, it's inactive, but you have chronic sequelae because you have no remyelination. Inflammation can markedly arrest, but it can smolder. So again, that's characterized by incomplete recovery. Or you can have really, really thin remyelination. That's obviously the best case scenario, and that is the scenario pathophysiologically that's associated with the best clinical outcome. And how exactly to get that to happen in all patients, I think that's an area of active inquiry. Why any single lesion? Think about those multiple sclerotic lesions that we saw in MRI. Why any single lesion responds the way it does following an episode of active inflammation is unknown. And so that is one of the reasons why the clinical course is highly diverse. The other reason, of course, being that these sclerotic lesions can occur anywhere in the central nervous system. The general average, shall we say, clinical course of your run-of-the-mill patient, if we average them all together, is progressive neurologic deterioration over a 10 to 20 year period. And this results in mobility deficits as well as cognitive deficits. Loss of bladder control is very common in individuals with multiple sclerosis. There are a whole lot of very expensive medications that exist and that a patient may be on. None of these medications reverse or even arrest the disease course, but they're all variably effective in slowing down progression. Okay, so that is MS. Next we're going to learn about neurodegenerative diseases such as Alzheimer's, Parkinson, and Huntington disease. These are diseases that are characterized by progressive loss of neurons. And these are not neurons that are lost in one specific anatomic area, but it's usually pathways of neurons. It's neurons that exhibit functional relationships, regardless of where they're located in the brain, that get entirely eliminated by one disease or another. structure into distinct clinical presentations, depending upon which neuronal pathways are affected. And so Parkinson's disease, for example, we will learn a quiz if we know. Parkinson's disease is a disease of which neuronal pathways? Individuals with Parkinson's disease are usually given what? Do we know? We'll get there soon enough. So much to learn. Another aspect of neurodegenerative diseases is the fact that they are characterized by accumulation of protein aggregates. You know, once upon a time it was 8 o'clock, and at 8 o'clock we talked about chronic neuronal injury in the setting of protein accumulation in the cell. And now we've made it. It's 9:25. We've made it to this part of the lecture. Are we on like slide 50 now or something?
66.
Wow, okay. So let's dive in. We'll learn about Alzheimer's disease, which is the most common neurodegenerative disease that accounts for maybe 75% or so of dementia in adults. We probably all have family members with Alzheimer's. Maybe not all, but many of us probably have family members with Alzheimer's disease. I've listed the percentages here. It's actually quite common with increasing age. It's characterized by fairly stereotypical and probably well known to all of us. You don't need to be in the medical profession. Very stereotypical clinical presentation of memory deficits, inability to orient oneself visually and spatially, even personality changes. Personality changes can accompany Alzheimer's disease. Difficulty speaking, cognitive difficulties, all emerge over time. There's usually a 10-year or so period in which the patient becomes increasingly disabled, unable to speak, and entirely immobile. There are unfortunately no management strategies whatsoever other than caring for your family member and being grateful to them for everything that they've done for you. The MRI shows in Alzheimer's disease generally a striking amount of cerebral atrophy. And an MRI together with the clinical presentation is diagnostic in most cases. Alzheimer's disease is a disease of amyloid. And so the fundamental abnormality is accumulation of two proteins, A-beta, which is amyloid beta or beta amyloid, and tau. And these proteins aggregate in tissue as plaques and tangles. And beta amyloid proteins aggregate in extracellular glial tissue as plaques, and tau proteins aggregate intracellularly as tangles. How these plaques and tangles accumulate, you know these words, plaques and tangles, that's very routine medical terminology. How these plaques and tangles accumulate is largely unknown, but the severity of disease is in correlation with the amount of plaques and tangles. Beta amyloid, this is a very interesting slide that we cannot talk about. So beta amyloid is a portion of an amyloid precursor protein whose function, or which function, is not entirely known. But this protein can be cleaved in such a way that it results in an amyloid beta monomer, which is the parent molecule of these amyloid beta aggregates, which deposit in an amyloid fashion. So if you do a PET scan for amyloid in Alzheimer's disease patients, it will totally light up. There is a normal physiologic way of processing this protein that cleaves it in such a way so that it is not at risk of forming amyloid. But there is a pathophysiologic way of cleaving this protein. You can see how a cut is maybe occurring here instead of right through it. There is a pathophysiologic way of chopping down, breaking down this protein that does preserve this entire structural unit, which is amyloidogenic. We'll just say that. Okay, what's very important, and maybe it will become extremely important over the course of your careers, although right now it's just an extremely interesting finding, is the fact that Alzheimer's disease is significantly associated with pigmentovalus. And by significant, I mean it's actually relevant, as opposed to the fact that periodontal disease is significantly associated with everything, right? And to the point where we don't actually know what that means, and in many cases it probably doesn't mean as much as the person who discovered the association is trying to state. But not only is there an association between P. gingivalis infection and Alzheimer's disease, but very importantly, P. gingivalis DNA has been identified in the brains of individuals with Alzheimer's disease and in individuals with very early pre-Alzheimer-like symptoms. Gingipains, which are the major virulence factors of P. gingivalis Gingivanes are also identified in these greens. So it really is possible there's a true pathophysiologic connection between periodontal disease and Alzheimer's disease that is a little bit better than, there's a correlation between summertime and or there's a correlation between ice cream consumption and death by drowning. It's because both occur in the summer, But there really probably is, there very well could possibly be a true association between periodontal disease and Alzheimer's disease. It'll be interesting to see how this develops and what role you all will play in patient management over the course of your careers. Okay, that's Alzheimer's disease. Parkinson's disease is neurodegenerative disease number 2. Alzheimer's disease is a disease of amyloid. We learned a little bit about beta amyloid. Parkinson's disease is a disease of dopamine, a disease of dopamine deficiency. And that's why these patients are treated with, and what I was trying to ask about earlier, if anybody knew, patients who have Parkinson's disease are treated with L-DOPA, which is a dopamine precursor that can cross the blood-brain barrier. Parkinson's disease is a neurodegenerative disease of dopamine deficiency. It results in a prominent hypokinetic movement, that is an inability really to move. We can think about Muhammad Ali at the end of his life and how long it took him to light the torch right at the Atlanta 1996 Olympic Games. This dopamine deficiency results in a total loss of dopaminergic neurons from the substantia nigra. Dopaminergic referring to the critical role of dopamine as a neurotransmitter in these cells. And the substantia nigra, just as a little reminder, it plays a very important role in movement and in dopaminergic pathways. Parkinson's disease is characterized by decreased facial expression, a very, very mute face, a stooped posture, and inability muscularly to stand up totally erect, slowing of voluntary movement with very shortened, accelerated snips, total rigidity, and sometimes the so-called hill rolling tremor just introduced a head and neck finding where the jaw is moving sideways a little bit as if it's rolling uphill. This constellation of clinical findings we simply refer to as Parkinsonism. Parkinsonism because it is very characteristic of Parkinson's disease, but Parkinsonism because these findings can also be seen in other neurodegenerative diseases, such as the ones I've listed here, that have damage to the nigrostriatal dopaminergic system. Parkinson's disease is characterized by the presence of Lewy bodies that are present in neurons, and these can spread from one neuron to another, perhaps in a prion-like fashion. I'll just point out very, very briefly in passing, in case you're bored on a date, conversation slow, there is something that's known as dementia with Lewy bodies. And these Lewy bodies will be present even in the frontal lobe of the cortex, where memory happens. Okay, the last of the neurodegenerative disorders we'll talk about is Huntington's disease. Huntington's disease is characterized clinically by this very well-known hyperkinetic movements that are jerky or chorea form. Chorea, the word chorea means dancing, right? Think choreography. So Huntington's disease is even known, in decades past as Huntington chorea because of this very, very characteristic jerky dance-like movement, these writhing of the peripheral extremities. Over time, there is slowing of movement and total rigidity. Huntington's disease is not only characterized by abnormalities of movement, but also by dementia. It is progressive, it is relentlessly progressive, it's uniformly fatal over a 10 to 15-year period. It's characterized by degeneration of striatal neurons, and this is almost always an autosomal dominant inherited condition. This slide I'll commit to you all. This is just a reminder for you all as to what striatal neurons are, what the basal ganglia is. You're probably well on your way of trying to remember these kinds of things. Pathophysiologically, Huntington's disease is characterized by cortical atrophy, particularly of the caudate nucleus, which I put an arrow of right here. And also within the cells, so here's the neuron, here's a little speck within it. This is an aggregate of Huntington protein, which I do not exactly know how it contributes to the disease course, but it's a pathologic finding. It's a very characteristic finding within the neurons. The disease, which I just want to mention ever so briefly, is something that's known as ALS, which stands for amyotrophic lateral sclerosis. I don't exactly know where the lateral sclerosis comes from, but amyotrophic, there's progressive atrophy and weakening of muscles. This is known as Lou Gehrig disease after the very famous baseball player who had this disease who had to retire early in his career. This is a disease of upper and lower motor neurons. So think about how your upper and lower motor neurons work. Either way, there is loss of muscle function. Why there is loss of these neurons resulting in loss of muscle function is somewhat poorly understood. There are some different therapeutic approaches based on findings in some cases. Clinical course consists of progressive muscle weakness, which is secondary to muscle denervation, which is itself secondary to lower motor neuron loss. Early symptoms consist of hand weakness and difficulty performing fine motor tasks. And with progression, there is involvement of larger and larger muscle groups, loss of muscle strength and bulk, spontaneous fasciculations, even dementia in some patients. Disease will eventually involve respiratory muscles, which leads to recurrent bouts of pulmonary infection. If you have difficulty breathing, you have difficulty exhaling oxygen and humidity and moisture and carbon dioxide. Average life expectancy is not long at all following death. Here's a picture of Lou Gehrig, who was a baseball player from a long, long time ago. You should YouTube or read Lou Gehrig's speech. It's really quite amazing, and it's very humbling to think about how some people live. Okay. Metabolic diseases can also affect the brain. They generally have a genetic basis, and they are inherited. And they are generally classified among the cellular components that are affected. Neuronal storage diseases, leukodystrophies, mitochondrial diseases as well. There's an extremely long list of genetic metabolic diseases. I hope that we're not going to talk about them too much. You see only one slide, and that's interesting. This is just one picture of one genetic metabolic disease. I put it on here only because it has a nice picture. If you look at the MRI, there's no white matter, and this genetic metabolic disease itself is called leukoencephalopathy with vanishing white matter. Neuronal storage diseases are diseases that are caused by deficiency of one enzyme or another that's involved in the catabolism of intracellular components, which then abnormally accumulate and are stored within neurons, leading to neuronal death and a variety of CNS functions. Leukodystrophies, as the name might suggest, leuko, these are genetic disorders of cellular tissue that results in defects in myelin synthesis, the white matter, right? So leukodystrophy. And this can lead to CNS-related findings as well. And then lastly, I'll point out that mitochondrial diseases can affect the central nervous system because the brain is so dependent on oxidative phosphorylation for energy generation. There's also all sorts of neuropsychiatric disorders. And then, has anyone heard of this book? The Man Who Mistook His Wife for a Hat? Okay, so my follow-up question will not be if anyone has read this book. But this is a very interesting book that describes all sorts of interesting neurologic and neuropsychiatric conditions with striking presentations. So, for example, the name of this book, Man Who Mistook His Wife for a Hat. This is a condition, this is about an individual who had visual agnosia. And so the book chronicles like 20 or 25 extremely interesting patients. And it's worth the read, I suppose, if you have the spare time. Okay, alcohol is not good for the brain. Alcohol is not good for the brain. It's an important teratogen, even in very, very small amounts. When consumed during the first trimester of pregnancy, that has very significant potential for risk to a developing child, to a developing human. Affected infants who are exposed to alcohol in the prenatal period prior to birth, they can show growth retardation, both in utero and also ex utero after they've been delivered. There's a variety of facial abnormalities that are characterized by a small head, these very, very narrow or short palpebral fissures, and underdevelopment of the maxilla. The incidence is unfortunately high, considering that this is something that can be addressed, that is within our own control. I'll briefly point out that vitamin B can be associated with central nervous system deficits. We're very familiar with vitamin B12 deficiency in the setting of autoimmune gastritis or some surgical procedure that has removed a portion of the ileum. And I won't say anything else about that. But vitamin D1 deficiency can also result in central nervous system manifestations. We have these two clinical presentations, Wernicke encephalopathy and Korsakoff syndrome. So Korsakoff syndrome being sort of a long-standing Wernicke encephalopathy. Wernicke encephalopathy is an acute appearance of psychotic symptoms as well as weakness or paralysis of the eye muscles. This is a reversible presentation with diamond administration. But it can progress to what is known as Korsakoff syndrome if it's unrecognized and untreated. Individuals who get Korsakoff syndrome are frequently chronic alcoholics. They nourish themselves entirely with alcohol, and so they're not getting the necessary vitamins and minerals and nutrients that they need, including not getting the water they need. Korsakoff syndrome is characterized by really, really problematic short-term memory and confabulation, which is really just making up stories. They're not doing this because they're intentionally lying. They're doing this because of the amount of damage to the central nervous system in the setting of vitamin B1 deficiency. Mercury can also damage the central nervous system. If somebody has been exposed to too much mercury, they can have a spectrum of manifestations that's termed erethism. Erethism. I hope I'm pronouncing that correctly. It's a word that I use one time a year. It's today. So mercury poisoning is associated with a spectrum of possible central nervous system manifestations, such as being very excitable, having tremors, having difficulty sleeping or staying wide awake, delirium. There is this phrase, mad as a hatter, that was historically described to individuals with mercury poisoning. And that's because mercury salts were used in felt processing, the felt that goes around the hat. And so when these salts were licked as part of the way of putting the felt onto the hat, every single time that happened, some mercury salts were being ingested. Mercury exposure does not happen commonly at all nowadays. And there are some other manifestations apart from central nervous system disease. But I will point out to you all for the sake of boards, and I would think not for the sake of encountering these kinds of patients with any frequency. But mercury poisoning can also be accompanied by gingivitis, taste changes, and sialorrhea, excessive salivation. Just as an afterthought, I will leave you all with this slide on mercury poisoning and dentistry. You probably are getting lots of opinions from many of your attendings, and that's great. And here's just one slide for you all to read as well. There does not seem to be a lot of evidence to remove amalgams or to not use amalgams in this country, but it's definitely a contentious and a poorly understood issue. In Europe, for example, amalgams are banned. And so I think some more research is needed in this area, although I think that it's not that big of a deal. Radiation can cause a variety of central nervous system manifestations as well. And radiation can occur in the setting of some tumor, benign or malignant, that is in the brain, and we will get to central nervous system tumors hopefully before 9:50. Even small amounts of radiation, as little as 10 gray or more, can cause central nervous manifestations. There can also be delayed effects. Delayed effects can occur as well, headaches, nausea, vomiting, as well as papilledema. Papilledema we'll learn about next spring when we learn about our head and neck diseases. Papilledema is optic nerve swelling, and that can be associated with visual disturbances. Radiation in the long term can also induce secondary tumors. We've learned about that in our neoplasia course, right? We had our characteristic example of a lady who had breast cancer who was radiated, and then she developed a post-radiation angiosarcoma. So radiation does carry a small risk for secondary tumor development. I mention, take the time for 15 or 20 seconds to mention radiation to the brain, because radiation is a common technique to address mass lesions that occur in the brain. Because neurosurgical access is frequently challenging, or it carries some kind of risk. So you can employ some sort of a technique such as this to target a mass lesion. Does anybody know what this is? So gamma knife. So for example, if you have some sort of device that shoots exceedingly small radiation doses, but shoots them from a very, very high number of different sources, each radiation dose, each radiation beam in and of itself is entirely insignificant, and it's much, much lower than 10 gray. But a physicist is involved in planning this radiation procedure, and a physicist is responsible for aligning all of these beams such that they all intersect in one area, the area of the tumor that is going to be treated by radiation. And so this is a way of ensuring that one part of the brain receives a necessary dosage of radiation to attempt to treat the condition, but all the other parts of the brain do not receive that dose of radiation. Okay, it's not even 9:50. And we're almost done. Let's go to. So the last thing we're going to talk about is the category of neoplastic disease, benign and malignant neoplasms to the central nervous system. As the numbers show here, this is not exactly a common category of disease, but it is somewhat common in a relative sense in children. It accounts for about a fifth of all childhood malignancies. Central nervous system tumors as a category of disease, they're somewhat unique, and that is because their diagnosis as benign or malignant is not necessarily the most important prognostic factor. Obviously, malignancies are bad prognoses for patients, but benign tumors can be as well, and that is because of where they might arise. And I see I've given one example here. We talked a little bit about tonsillar herniation and some of the life-threatening effects of tonsillar herniations. That's just a physical pressure-related change. Imagine if you have a tumor that is growing in such a place that it compresses the medulla. That can cause really, really important and life-threatening symptoms. Imagine if you have a totally benign tumor like a meningioma, which we'll learn about soon enough, and you won't need to know meningiomas. Imagine if you have a meningioma that is in an inaccessible location surgically and that is compressing the optic nerve. That's extremely unfortunate because you're going to have really pronounced visual deficits that are difficult to correct. So benign neoplasms can be a really significant cause of morbidity. Benign neoplasms can also be highly, highly infiltrative, and they can be not amenable to resection. Also, tumors that encroach upon the subarachnoid space, they can spread all throughout the brain and spinal cord via the cerebrospinal fluid. I will point out here, as an aside, that it is very uncommon for brain tumors to metastasize to some other part of the body. But the opposite is actually very much true. As many as a half of all brain cancers are metastases from the lungs, the colon, prostate, breast, you name it. So CNS tumors are assigned one of four grades. And we're all very familiar with grading. We get grades all the time. We wouldn't be here if we didn't make good grades all of our lives. But CNS tumors are assigned one of four grades, and it's actually the grade of the tumor that is just as important, if not more so, in a particular diagnosis, prognostic for the patient. And so tumors can be grade 1, 2, 3, or 4. Grade 1 being the best, and grade 4 being the worst. Tumors which recur, like you attempted radiation or you attempted surgery, but the tumor was just in a difficult location or couldn't entirely be removed. Tumors that recur usually recur as a higher grade. So many individuals, even who have a benign tumor, it may eventually be their cause of death 30, 40 years down the road. So let's learn about some central nervous system tumors. The first one to learn about, and the most important one, is the meningioma. Meningiomas arise from meningeal cells, and they're typically in association with the dura mater. They're usually attached directly to the dura mater. These are the single most common primary brain tumors. So again, common things. Commonly, we need to be developing some sort of a list, even though there's so much to learn. There's so many diseases in the human body to learn about. But we need to have some appreciation of what's common and what's not common in all of our different organ systems. That will really help us one day when we evaluate our patients, and we don't want to spend more than 30 seconds going over their medical history, and we won't need to because we're going to know medical conditions very well. The meningiomas are the single most common primary brain tumors. They usually arise at a low and older age, and they're usually low grade, although they can be Meningiomas are slow growing. They're usually asymptomatic unless they're in a very unfortunate location, compressing some vital nerve. Some patients do have neurologic deficits secondary to compression of a vital structure. Some patients do get seizures. Meningiomas are managed either with surgical resection or radiation, or in some cases, in many cases, as a matter of fact, they're managed with close observation if they're asymptomatic and if they don't pose some impending significant risk. So tumor number 1 is meningioma, and number 2 is a category of tumors that's known as gliomas. Gliomas are tumors of glial cells, right? And we're learning all of our glial cells. And so gliomas as a group are much more common than meningiomas. Gliomas as a group are much more common than meningiomas. So as a group they're common, but there's different kinds of gliomas. And we will just spend a slide on each of these just for the sake of our own education. We have astrocytomas, which develop from astrocytes, or which are neoplastic astrocytes. These represent the most common glioma. If you hear the word glioma, some famous celebrity has a glioma and they're an adult, they probably have an infiltrating astrocytoma. And that individual probably has a grade 2 tumor, but it is usually difficult to remove. They're called infiltrating for a reason. They're all over the place, and it's very difficult for a neurosurgeon to get all of it out, or for radiation therapy to address all of it out. With time, these individuals can have seizures, headaches, and even focal neurologic deficits. Over time, the clinical course is slowly progressive, and it invariably goes to a higher and higher grade. Astrocytomas can also occur in children and young adults, and when they do, they have a very good prognosis. They're slow growing, they're easily treated with resection, they're low grade. Oligodendrogliomas are neoplasms of oligodendrocytes. They look like little fried eggs, microscopically, so they're very, very cute. These are very rare. They're typically not suspected clinically, and a common clinical presentation is years of seizures for an unknown or undiagnosed reason. Ependymomas are tumors of ependyal cells that line the ventricular system. And so as a surprise, it should be no surprise that it's very, very common for these to disseminate throughout the ventricular system and everywhere cerebrospinal fluid goes. These frequently occur in adults in the spinal canal, where there can be localized pain, and where they're actually fairly easily treated by surgical resection. In children, they will occur in the area of the posterior cranial fossa around the fourth ventricle. The prognosis is actually a little bit more guarded. This is going to be an example of a neoplasm. This is an adult lesion. But a pediatric ependymoma that's occurring around the fourth ventricle is an example of a neoplasm that might present as hydrocephalus. Okay, the word glioblastoma is a word that we need to understand. A glioblastoma is a grade 4 tumor of any type. When an astrocytoma becomes grade 4, it's a glioblastoma. And it's really an afterthought that glioblastoma arose from an astrocytoma. If an ependymoma becomes grade 4, prognostically, significantly for the patient, it's a glioblastoma that happened to arise from ependymoma. So glioblastoma is a grade 4 glial tumor of any type. Glioblastomas occur in older individuals or in somewhat younger individuals who, as we talked about with astrocytomas, have a history of a glioma of one or another type, and slowly but surely finally make it to grade 4, and so now there's a secondary glioblastoma. Glioblastomas are bad news for patients. Median survival is a year or 2 at most. Okay, 2 more slides. Medulloblastoma is a cancer that's worth being introduced to for a couple of reasons. Medulloblastomas are highly aggressive malignancies of the cerebellum in children. They're actually associated with a fairly good prognosis in most cases. Symptoms can be related to increased intracranial pressure or cerebellar dysfunction. Medulloblastoma is worth keeping in the back of your mind because there's a syndrome that you all should know very well. It's characterized by meningocysts. It's called nevoid basal cell carcinoma, or Gorlin syndrome. We've encountered this syndrome before, and we will talk about it again next spring. And Gorlin syndrome is characterized by medulloblastomas. Lymphomas can also occur in the central nervous system. We call them primary to distinguish them from lymphomas somewhere else in the body. CNS lymphomas are somewhat common in immunosuppressed individuals. They're one of the more common cancers in AIDS patients. Okay, we made it. Any questions? Yeah.
I think I have a couple. The one is last lecture you talked about the pituitary tumor. It is kind of like the base of the brain, so it is not belong to the brain tumor.
So pituitary tumors are an example of brain tumors. But physiologically and in terms of clinical manifestations, they're much more likely to present with endocrine signs and symptoms than neurologic signs and symptoms. Yeah. But if you remember correctly, one of the things we talked about with pituitary adenomas is a slight increased risk of headaches and other sequelae associated with increased intracranial pressure.
Okay. Second question is about the Golin you just mentioned. Last time you mentioned the Golin is about the skin tumor, the BCC part. Now
Absolutely.
you talked about the medulloblastoma. So that means the etiology is the same about the hedgehog pathway.
Exactly. So Gorlin syndrome is a disease whereby you've inherited a mutant gene from your mom or your dad. So every cell in your body has a mutated patch1 gene. And if you have a mutated patch1 gene, you're at increased risk of getting diseases like basal cell carcinoma, medulloblastoma, keratocystic odontogenic tumor, and everything else that you commonly see in that syndrome, and which we'll go over again in the
Okay.
spring. Yeah.
Thank you.
Good question. Okay, thank you all.